Good afternoon. My name is Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Johns Hopkins Bloomberg School of Public Health, it is my pleasure to welcome the Maryland Department of Health and Mental Hygiene to our school, with an especially warm welcome for Secretary Colmers and Deputy Secretary Fran Phillips. I appreciate them joining us today to provide important information to registered H1N1 vaccine providers in the state of Maryland. Here in Maryland, we're extremely grateful to the leadership of the Department of Health and Mental Hygiene. Not only have they been keeping Maryland at the forefront of addressing the threat of H1N1, but at a time when budgets are being cut to the bone, resources are hard to come by, and the number of uninsured around the country continues to climb, they have succeeded in the past year in actually reducing the number of the uninsured in Maryland. In working to prevent the spread of H1N1, the department has similarly gone the extra mile, forging new partnerships with employers, educators, and health professionals to ensure we are all involved in a proactive approach to keep Maryland healthy now that H1N1 is here and the new flu season approaches. Before I turn this over to our moderator, Dr. Sybinsky, I invite everyone online to take an opportunity to explore our website and the trainings we offer, and to take advantage of our public health training resources. And finally, I want to remind all those watching online that we will be taking questions at the end of the presentation via email, and you can send your emails to maphtc@jhsph.edu. Thank you.
Good afternoon. I'm Pete Sybinsky, moderator for this event. We're very fortunate to have DHMH H1N1 senior leadership team here today to provide the status of the key elements of the campaign in Maryland and to address questions from the registered vaccinators who are watching the live webcast. We encourage all participants to email questions to maphtc@jhsph.edu anytime during this webcast. I'd now like to introduce our panelists. Today's presentation starts with the DHMH Secretary, John Colmers, with a welcome from the department. Fran Phillips, Deputy Secretary for Public Health Services, will give an overview of the H1N1 situation. Dr. David Blythe, State Epidemiologist, will cover continuing surveillance of the disease. Ms. Heather Hauck, Director of Infectious Disease and Environmental Health Administration, will cover the H1N1 vaccine campaign. And Mr. David Paulson, Director of Communications, will address the campaign's efforts to communicate with providers and the public. Although not a panelist, we have Mr. Daniel O'Brien, Principal Counsel to DHMH, here as a resource to address legal questions. We'll hold a question and answer session after the formal presentation. Please email us your questions at maphtc@jhsph.edu. Those providers attending this webcast in the audience can also write their questions on blank cards that we have left at strategic points in the auditorium. If you've drafted a question, please hold up your card and a staffer will bring it to us. I'm now going to begin today's proceedings by inviting Secretary John Colmers to the podium. Secretary Colmers.
Thank you very much, Pete, and good afternoon. First of all, great thanks to the Bloomberg School of Public Health here to allow us the opportunity to conduct this webinar and to be able to speak directly to those who have registered as vaccination sites around the state of Maryland to provide up-to-date information about the status of the outbreak and the steps that we are taking in collaboration with you to get the vaccine into the immune systems of as many Marylanders as possible. Particularly at the Bloomberg School, I want to thank Dean Clagg for his leadership and his collaboration that he has shown over the many months and years. It is remarkable to recall that it is literally just 6 months ago that the first reports of H1N1 in cases here in the United States were made. And yet in this 6-month time period, we are already at a point where we have a vaccine developed and approved, a vaccine that is ready to be delivered, and the undertaking of a significant public health vaccination effort, the likes of which this country has not seen for several generations. It is a remarkable effort indeed, and while we will see that there are going to be problems along the way as this develops, we cannot lose sight of the fact that much progress has already been made. The vaccine that has been prepared, we know will be effective, but we also know that it is being developed and produced, I should say, at a rate less rapid than we had originally thought. Based on guidance from CDC, we will be targeting 5 target populations to begin with. Those target populations are pregnant women, children and young adults from 6 months of age to 24 years, healthcare workers, those who live with or work with children under 6 months of age, and adults between 25 and 64 who have a pre-existing healthcare condition that place them at higher risk. That accounts for 2.9 million people here in Maryland, those target populations. So while the vaccine has been delayed in its production, please be assured that we are doing everything that we can to make it available and are producing and ordering every amount of vaccine that is made available to us on a daily basis. You'll be hearing more about what that process is today. Also, given our focus on the target population, it's important to recognize that our focus will be on that population because of the epidemiological data that suggests that these groups are at higher risk of the disease, and therefore we'll focus on them. That, of course, has implications on who will be receiving the vaccine and under what formulation is appropriate for those individuals. Finally, it is also important for us to keep and be as transparent as possible, and that means for us to be able to have communication both to all of you and to be able to hear from you as well. And so we welcome this opportunity today. Thank you very much.
Well, good afternoon. Moving on to the presentation, my name is Fran Phillips. I'm Deputy Secretary for Public Health. And again, I do, along with the rest of the department, sincerely appreciate the efforts of all of our community partners, the vaccinators, the physicians, the countless numbers of practices, clinics, health departments, hospitals who have stepped up and will be joining in this effort. As Secretary Colmers indicated, what we are facing in 2009 with regard to influenza is unprecedented. It was in the third week of April that a novel virus was detected here in the United States, and it is tough to imagine that that was only 6 months ago. As a result of that introduction of the novel virus, a massive campaign has taken place, really of historic proportions, in a very short period of time to isolate the virus, the new virus, to grow it, to produce vaccine, to have that vaccine licensed and approved, and now moving to the distribution of that vaccine, which the federal government has committed to offer to every American who would like a dose. So that's a tremendous amount of activity in a very concentrated period of time. We know that the consequences of that have been some bumps along the way, not the least of which, and not unrelated to that accelerated H1N1 vaccine production, has been the disruption, as we are seeing now in certain areas of the country, the disruption of the supply of seasonal vaccine. We are also seeing uniquely in this 2009 campaign a governmental distribution plan for the new vaccine. This is different from certainly the seasonal vaccine, which is distributed to end users through the typical commercial distribution system. Not so with the H1N1 vaccine, and that is in large part what we hope to talk with all of you about. So moving on to the purpose of this webcast, this presentation, really three key purposes for our primary intended audience, and that are the over 2,000 vaccinators who have now registered with the state health department to be a vaccinator of participating in this H1N1 campaign. So looking and thanking all of you registrants. Our purposes here are threefold. One, to inform you of the epidemiology of H1N1 in Maryland. Secondly, to describe the vaccine ordering, shipping, and reporting procedures as it comes from your orders to your door. And then thirdly, to offer all of you some additional communication pathways by which you can enter into a dialogue with us to improve this campaign. So again, thank you so much.
Well, hi, I'm David Blythe. I'm with this Department of Health and Mental Hygiene, and what I'm going to talk about is why we're doing this. Why are we doing this big vaccination campaign? And I'm going to go through a little bit about the epidemiology of this 2009 H1N1 here in Maryland, and just briefly overall. So let me first acknowledge the people here in this room, and then also, I'm sure, on the webcast, who are really helping us figure this all out, what's going on, and that's the providers and others who participate in our surveillance activities. And I'm going to briefly describe what we have going on here in Maryland and show you a little bit of the data. So overall, we look at several different indicators to try to get a sense of what's going on with the 2009 H1N1 and with influenza in general. So we look at overall activity indicators, indicators of severity, and then we particularly monitor the virus itself. So we try to characterize or do a characterization of the virus. And I'm going to briefly touch on these various elements of that activity and then show you some information from these various systems. So we have, as indicators of overall activity, we have something called the ILI-NET, or Influenza-like Illness Network, of Sentinel providers, and that's a group of, in Maryland, about 60 plus providers throughout the state that weekly report influenza-like illness activity among the patients that they see. And so that's and that's been a system we've had in place for years, but been crucial for our understanding of what's going on this season as well. We also have an internet-based survey of Maryland residents, about 1,000 or so Maryland residents throughout the state, who weekly report their own experience with influenza-like illness, fever, and cough or sore throat, so that we can keep track of people who don't encounter the healthcare system, because as you'll see as I go through this real briefly, most of our information comes from healthcare settings, but this gets a picture of what's going on in people who don't seek healthcare. We also monitor emergency department visits for influenza-like illness. We have Sentinel clinical labs, 30-some throughout the state, that report on a weekly basis the percentage of the tests that they do that are positive. And we look for outbreaks of influenza-like illness in various settings like schools or long-term care facilities. We also monitor for severity, and we look at hospitalizations for flu, lab-confirmed flu throughout the state, and then also death. And unfortunately, we have seen deaths associated with this particular virus here in Maryland, and as you guys know, throughout the United States. And then finally, we do get specimens into our lab to track the subtypes of influenza that are circulating and try to look to see if there are any changes in the virus sequence, the genetic sequence, to indicate either increased virulence or some important change in the virus itself. We also do testing for antiviral resistance because that's going to be an important component to our control efforts. So just real briefly, here is a picture of the most recent snapshot of what's been going on in Maryland, and I won't go over this in great detail, but these are our overall activity indicators, the ILI-NET providers, the survey, the ED visits, that's the Essence system, and then the tests that are positive. And this part of the curve is back last February and March, and that was our seasonal influenza epidemic last year. Then a drop off. Then we see this increase here, and this represents the initial wave of H1N1 activity last spring, and that dropped off, although this lab testing piece continued to persist through the summer. However, you can see now in the early fall, we're seeing this dramatic increase in all the indicators of activity. So they're all peaking and at levels that are close to or even exceed what we saw last spring with seasonal flu. So everything is up. All the indicators are up here. In addition, this is ED visits here in this black line, but in addition, we see hospitalizations here in these bars. And those have also increased recently, maybe a little bit of a drop-off this last week, and we hope that indicates something lasting, but we'll see. So hospitalizations are up, and again, unfortunately, we've also seen deaths. I'll mention that almost all the activity that we're seeing currently is the 2009 H1N1 activity. We've seen only 3 seasonal flu cases here in the last 2 months. So it's almost all 2009 H1N1. And just one other thing to say about hospitalizations. About 45% of these hospitalizations are in children less than 18, so in the pediatric population. So you heard about the target groups, and that's one of the target groups, and that's why. And in addition, about 4% of these hospitalizations have been among pregnant women. So just in sum, we have widespread distribution of cases throughout Maryland, throughout the United States. The illness, as many people know, has generally been mild, but it can be moderate or certainly severe in some people who have underlying risk factors for complications and can be as severe as to cause death. So far, this epidemic has disproportionately been impacting younger people, children in particular, but younger adults as well. We've had over 200 hospitalizations here in Maryland for novel or 2009 H1N1, included have been 10 deaths to date. And we have lots of outbreaks, 88 flu-like outbreaks as of this past, earlier this week. So I'll stop there and we'll move to the next section here.
Good afternoon. I'm Heather Hauck. I'm the Director of the Infectious Disease and Environmental Health Administration at DHMH. Many of you may know or may have spoken with Greg Reed, who is the Chief of our Center for Immunization within the Infectious Disease and Environmental Health Administration. I want to start by acknowledging his leadership and the hard work of his staff within the Center for Immunization. This section of the presentation is a presentation that Greg typically would do. However, he is actually in Atlanta getting updates on vaccination and H1N1 issues for us. As the Secretary and the Deputy Secretary have indicated, this is a rather unprecedented public-private partnership for this campaign, with the initial focus being on the target populations that the Secretary indicated. It's a centralized distribution system through DHMH, and I'm going to talk through a little bit about how that distribution is working currently and how it will work in the future. As you all have probably heard, there is no cost for the vaccine or the supplies. The federal government, as the Deputy Secretary indicated, has committed to providing vaccine and supplies for every person in the United States who would like to receive a dose of the vaccine. And they are producing, the manufacturers are producing various vaccine formulations, multidose vials, LAIV, and single-dose pre-filled syringes. I will note that we are currently getting very little of the adult pre-filled single-dose syringes, so that is the one area among all of the others that we seem to be lacking significant quantities of the vaccine. I'm going to take just a second to walk through the timeline. As the Deputy Secretary indicated, this has been a rather compressed timeline for the initiation of the vaccination campaign component of our H1N1 experience here in the United States. Although we at DHMH have been planning and working diligently since June, sitting together talking about vaccination, it really was not until August that we began to really see from and get information from CDC about what was going to happen in terms of this, the operationalization of the vaccination campaign. We sent out a request for anticipating that there would be a process that we would need to follow in order to work with you all as the provider community We sent out a request for a pre-registration in August of 2009. It's an internet-based pre-registration process on our website, and we are, as of today, continuing to pre-register providers who are interested, have indicated that they're interested in providing H1N1 vaccine to their patients or to the community. To date, we have over 3,400 vaccinator providers pre-registered on the website. We then go through and we verify that the provider who has indicated that they would like to provide vaccine is able to do so. They have a medical license and they have the ability or an ability by statutory authority to deliver H1N1 vaccine. And we issue them a special PIN number that will allow them to work with us in the ordering of the vaccine and the receipt of the vaccine. We have been issuing those PIN numbers since September, and again, as providers register and we're able to verify them in the pre-registration system, we issue a PIN. We also have been working since August around the Vaccine Administration Tracking and Reporting Form. CDC requires that we report on a weekly basis certain data elements so that they can have a better understanding of what vaccine is being delivered in our states. And so we actually developed 4 mechanisms for these required reporting elements. The first is a scannable form. When you receive your vaccine, you also receive a box of scannable forms, which the patient can fill out, and the provider must also fill out a section on that scannable form. When those are completed, you may batch them and send them back to the address that's contained in the box, where they will be scanned and entered into our data system. The second methodology is electronic data transfer. Many large providers may choose to actually submit their data to us electronically, and we've established a process where we may discuss your ability to do that, and we may be able to accept that information electronically. The third mechanism for reporting is Immunet. Many VFC providers already report through Immunet, and certainly the data elements for this particular vaccine may also be submitted to us through Immunet. And then the fourth method is through a school consent form. Many of the providers on this webinar today may not be engaged in the school-based vaccination clinics, but if you are, there is also a separate school-based consent form that can be completed and sent in to us in order to complete the data reporting. And then lastly, we sent out a vaccine provider agreement that was available for completion on September 28th. All providers who are able to do H1N1 vaccine ordering and vaccination must complete that provider agreement and submit that to us. At about the same time, we received notice from CDC about exactly how much vaccine will we be able to order on the first day that it became available. We were told on September 28th that we would be able to order 55,000 doses of LAIV. And we could start ordering that on September 30th. And we did exactly that. We placed an initial order for 55,000 doses of LAIV. And it has been a process, a daily process, of exactly that since September 30th. We receive pre-registered providers. We issue PINs to providers on a daily basis. We receive a daily notification from CDC if there is any additional allocation of vaccine to be ordered, and if there is, how much may we order in the various formulations. We place the orders for that vaccine, and I'm going to talk in a minute about how those orders are placed. And then we, of course, have an ongoing receipt of the Vaccination Administration Tracking Report forms. To date, or as of yesterday, we had been allocated from CDC and ordered 233,000 dosages of vaccine in the multiple formulations. As the Secretary indicated, by the end of November, based on the CDC projections, we will have about 1.6 million doses available to us, and will have ordered 1.6 million, all the 1.6 million doses that are available to us by the end of November, which is certainly a significant reduction in the original projections we had had from CDC about how much vaccine would be available by the end of November. So in terms of the ordering process, I've already described the pre-registration process. I've already described that we verify the providers and issue a H1N1 vaccination PIN. The vaccination providers then complete the provider agreement on the website that allows us to then register you completely and take your order for vaccines. And at the same time, you are also provided with guidance, instructions, and a vaccine order form on the DHMH website. That vaccine order form comes to us electronically, and we on a daily basis are again reviewing that information, those forms, and making some decisions based on our daily allocation from CDC on the orders of vaccine that can be placed. We are, first of all, prioritizing providers based on the target populations that they are able to serve. As the Secretary mentioned, there are the 5 target populations, and therefore we are culling through and prioritizing providers who are OBs, pediatric providers, family practitioners, local health departments, federally qualified health centers, and hospitals, because those are the entities that are reaching those 5 target populations. We are also looking at geography, because we certainly want some vaccine to be available in every jurisdiction to the extent that we can provide it. And again, all of this is based on the formulations that are available to us. As I mentioned, we currently are not receiving hardly any quantity of prefilled adult syringes, so we're relying mostly on LAIV and multidose vials because that's what is available at this point. So again, we're looking at what was submitted on the provider order, what type of formulation, is the provider serving a target population, geography, and then we are additionally restricted in that we can only ship greater than 100 doses. So we're also looking at the size of the request to ensure that we're able to provide some amount of vaccine. We certainly are aware that because of the reduction in the allocation, which is of course based on the reduction in the production of the vaccine by the manufacturers, we are not in most cases able to provide complete orders. We are at this point only able to provide some amount of the overall order that were submitted by the providers with the goal of distributing vaccine across the state so that we may reach the target population. We also provided sort of a visual flowchart that essentially shows you exactly what I just described in terms of how it gets from the manufacturer. CDC tells us how much vaccine we can order on a daily basis, what we're doing in terms of notifying McKesson, which is the central distributor, of what the order is that should be shipped to the various providers, what you all as providers are completing in order to participate in the vaccination campaign, and then, of course, the reporting process as well, coming back to DHMH so that we can report to CDC on a weekly basis the number of dosages that are being administered in our community. Again, a reminder about reporting. In the provider agreement, it specifies the requirement to report the data elements. It specifies the data elements, and I've already spoken briefly about the 4 ways that providers can provide those reports to DHMH. We certainly understand that there are concerns or questions about your orders or other areas in terms of the registration process, et cetera. All of those inquiries should be emailed to h1n1info@dhmh.state.md.us. We will be able to respond to your inquiries and provide you the appropriate information. And also a reminder that if there are adverse events, you are required to also report through the VIR system. So as you've heard from the Deputy Secretary, the Secretary, and you'll hear from all of us today, we are certainly aware that there are many current challenges with this vaccination campaign. Certainly you've heard about the supply delays and our need to daily prioritize the vaccine orders in a way that hopefully provides vaccine statewide to the target populations. We also have heard that there are some concerns and some issues with the supplies that are being shipped alongside the vaccine. The supplies do arrive separately, and we have heard that there are some issues with needles, there are some issues with the syringes. CDC has established an email address. If you have concerns with those supplies or have a question about those supplies, please do email those to CDC so that they are aware of those concerns. We are also translating those concerns to CDC so that they may talk to their supply distributor and their supply manufacturers to see if there's a way to address those concerns. We also are aware that our communication with vaccination providers regarding the ordering process has been bumpy, as the Deputy Secretary acknowledged. This has really been a process of being able to transition from our traditional immunization process and ordering process to really more of a Amazon.com type of a business process. And so we have been working diligently to try to automate some of our communication with vaccination providers so that you will know that we have received your order, and then you will be able to know that we have placed an order on your behalf and in what quantity we have been able to place that order, again, based on what our daily allocation is and the formulations that are available. We anticipate that we will be able to do that in the coming week or coming week and a half. So please look forward to receiving those email communications from us in the near future. And as always, if you do have questions about your orders or about other issues, please do email us at the H1N1 info at dhmh.state.md.us. Thank you.
Good afternoon. I'm David Paulson, Director of Communications for the Department of Health and Mental Hygiene. Very quickly, I'm going to go over some communications elements which have been important to this campaign. First of all, the State Department has communicated regularly, usually through email, sometimes through the website, to all of the licensed physicians, nurses, pharmacists, state and local school, health, emergency management, and EMS officials, hospital and retail pharmacies, major employers, nonprofits, and universities, and other state agencies. It's that broad of a campaign in which we need to communicate on a regular basis with all of them. We have, for the use of not only physicians, nurses, pharmacists, healthcare providers, as well as their patients, an enhanced website dealing specifically with the H1N1 swine flu virus. It is at www.flu.maryland.gov. That is the site at the DHMH website. It combines all of the information that we can make public, FAQs, provider information, as well as links to the federal websites that are helpful in background not only for individuals seeking treatment and information about the swine flu, but also to physicians and professionals in the field. We also have provided for the public a flu information line, 1-877-MD-FLU-4U. That number is currently receiving calls from members of the public asking specific questions, the majority of those questions regarding to where can I get the vaccine at the moment. We also have created a speakers bureau in which to allow us to respond to personal requests for individuals to come and speak to groups and organizations, and have been able to facilitate a lot of one-on-one or one-to-group communications that way. And we have planned both an earned media and a paid media campaign. We're in the middle of the earned one, where we try to communicate through the press, the local press, as best we can, what developments are taking place and what we're doing. We have plans, a limited amount of funds to do a paid media campaign through PSAs, both broadcast, print, and outdoor advertising. That campaign has been delayed to a date uncertain at this time because of the supply of the vaccine that we're having now, and we see, of course, that the demand is exceeding the supply. I want to reiterate what the Secretary had said a little bit earlier about our three key messages we want you to understand today. We order every drop of vaccine that's available to us, and as we are told every day how much we can get, we order all of it. And as you know, the deliveries that we have expected for the month of October have been delayed until the month of November and so on. Our vaccination focus continues to be the target groups, the target populations that have been discussed. That will continue until we reach a point where we're able to do a broad distribution of the vaccination product. We don't know when that's going to be exactly. We expect sometime mid to late November. In the meantime, we are very open to suggestions on how we can better reach the target populations with this vaccine, and we are anxious to advance that discussion. And with that, let me bring forth Dr. Pete Sybinsky for questions and answers.
Thank you very much, David. We're now at the opportunity to take questions and from both our web and live audiences. Again, for those online, you can look at the screen and the address that you can email your questions to is maphtc@jhsph.edu. We've already got a few good questions already. So the first question comes, and I think anyone on the panel might want to take a shot at this. The provider heard that the virus will hit its peak this week, and if not already vaccinated, it is now too late. Is this true?
I'll take a stab at that, and then others can address it if they like to. I hope this is a peak of activity. We'd certainly like to see the level of influenza activity drop off. But we certainly don't know that at this point, and we don't, and so certainly cannot say that. And then the second part of the question was, well, if this is the peak and then things drop off, what's the point of getting vaccinated at that, if that's the case? Well, one, I think we certainly don't know who has, people with influenza-like illness may have an influenza-like illness that's caused by some other respiratory pathogen, so that wouldn't be flu. And if that is the case, then they wouldn't have develop antibodies against flu, and so wouldn't be protected against a later wave of influenza activity. And so for that reason, because most people who have this are not being tested and therefore not being confirmed to have H1N1, we would recommend that people continue to get vaccine. One, they may not have been protected, and there may well be additional waves of influenza activity, even if we see a peak and a decline here recently. So I'll stop there and see if others have comments about that part.
David, if I might, I'd just add on to it. It's not just looking at it in terms of the population as a whole, which of course is one way of looking at it, but looking at it as from the individual standpoint. So for you and for your family members, it may still be important, even if we are get to a point beyond the peak, to protect yourself, your family, and your community. I'll also hasten to add that there are models out there that predict the growth of this virus. They have largely, this virus has largely been very different. We didn't expect to see viral activity spread throughout the summer. It was percolating throughout the summer. This is not the time of year that one expects to see the growth of the virus in the community. It is growing and continuing to grow in the state. So while there are studies that have done, we're aware of, that are out there, you need to think of it individually and need to question whether or not those are going to be accurate predictions or not.
Okay, the next question. As healthcare providers of seniors who have families, children, and grandchildren, where are we on the list of priorities? Our staff love children and are concerned about bringing the virus home.
Well, I'll start because I understand that this is a question that this is rather different. This is yet another way that this H1N1 vaccine is different from the seasonal vaccine, where it is every bit a concern that older people get vaccinated, as they are at significant risk. As Dr. Blythe has indicated for our state stats as well as nationally, the disease seems to disproportionately impact younger people under the age of 24. Fully 50% of the hospitalizations are for younger people. And so the concern at the initial phases, while we're working on a priority population prior to offering the vaccine to the entire public, is to vaccinate the people most at risk of serious consequences. And for this virus, which is different from seasonal, that is younger people as opposed to older people. However, there are a category of older people that shouldn't be left out, who are very much in that target population, and that is grandparents or other folks who are taking care of infants. So one of the important categories to consider are those people who are household contacts or caregivers of newborns all the way up to 6 months. These infants are too young to be vaccinated themselves, and so the people around them need to protect those babies, and that often can include grandparents.
Okay. Next question. As an inner-city health clinic, when can we find out when to expect the vaccine?
Again, if you have a specific question about your order, I would encourage you to email it to H1N1 info, as was indicated in the presentation. We certainly, again, are looking at the orders as they come in. Even if you've registered recently within the last day, we are looking at those on a daily basis and prioritizing, again, based on the formulation that you're requesting, the population that you're serving, and geographic distribution. So we can address your specific concern via email, but again, those are the criteria that we're using to distribute vaccine.
And if I could add again, we have placed orders for 230,000 doses. The target population is 2.9 million. That's about 8% of the target population that we've placed orders for. We had originally anticipated that by the end of October, we would have 1 million doses available to order for the state of Maryland. We won't hit that 1 million dose mark until either the second or third week in November. So what we are seeing is a delay, if you will, a phase shift in the production of this to a point in time where we had thought by the end of October, early November, to have a sufficient amount to make available generally to a point in time later in the month of November.
Okay, the next question is probably for Heather. We've registered for the pre-filled adult syringes. Since they are coming out slowly, is it possible to get the actual multi-dose vials with the needed supplies to vaccinate instead in order to begin vaccinating the priority patients?
It's a good question. Thank you. At present, we are developing a form that we anticipate being able to use with the general provider community for there to be a modification to your order. It's not yet available to the general provider community. When that is available, we will be contacting the vaccination providers and allowing that opportunity. But again, at this point, we don't have that mechanism in place to allow an adjustment in the orders for the general vaccination providers, but we'll certainly keep you informed, and when that is available, can give you that opportunity to revise the order.
Okay, here's a medical question for Dr. Blythe. Patients claim their children have been diagnosed with H1N1, but no testing was sent out to confirm this. Number one, do these children still get the vaccine? And a second question, which is a little bit different, do providers prophylaxis the patients who are compromised based on that data, which is really no confirmation?
So let me take a general stab. I mean, there are many people who have had influenza and influenza-like illnesses, but most of those people have not had specific confirmation of the H1N1 activity. So the question, can people still be vaccinated if they've had an illness that was said to be H1N1, but there was no laboratory confirmation of that? And the answer is yes, they can still and should be vaccinated if they fall within one of those target groups, at least initially. And secondly, the question about prophylaxis, and again, we can get into the details, but in general, the recommendations for prophylaxis are for people who are at risk for complications if they are infected with influenza, special groups, and they're pretty rare situations where that would be indicated and needed. However, if a person was, if a patient had an illness but it had not been confirmed to be H1N1 by specific H1N1 testing, then the provider should go ahead and treat that as if it could have been some other illness.
Thank you. Will school-age children receive the vaccine in schools? And also, should younger children be vaccinated before older children? I don't know.
I'll start with that, and maybe repeat the second part of the question. The answer is yes, but be patient. Clearly, we talked about how children are in the target population. Schools are a great place to get to children. In Maryland, every county has experience with school-based vaccination, flu miss campaigns for seasonal flu in elementary schools. Every local health department is a tremendously important and strong partner in this campaign across the state. Every local health department has worked really, really hard to understand the needs of the target populations in their jurisdiction, to work very closely with their schools so that when vaccine is available, and there's no one more anxious to get that vaccine than county health officers right now, when vaccine is available, then certainly moving that vaccine to schools, whether that's in school or after school hours, whether that's the nasal spray or the injectable or some combination of both, every county health department is anxious to start school-based clinics. These are school-based clinics that will apply not only to public schools, but the opportunity to vaccinate and to make that vaccine available to all non-public school students is a commitment in every county across the state. So when it's going to start is a really tough question to answer. The best that we can say now, as far as looking ahead and trying to get some visibility locally on where the next either public clinic will be held or school-based clinic will be held, will be with the local health departments. Local health departments have websites, they have flu lines, and so a way to collect all those local jurisdiction information is to go to the state health department's website, where you can click on a map to your county and then drill down and to get the local information. So the state website to look and see what's happening locally is www.flu.maryland.gov. So if you go on there, you can then get to your county. Again, not every county has announced clinics, either in schools or publicly. All county health departments have some initial doses of vaccine, and all county health departments are immunizing people right now in that target population. As I think you know, this is a moving target as far as the vaccine supply, and so daily we order on behalf of local health departments with the idea that along with the pediatric providers, the OBs, the hospitals, the local health departments are really the provider of last resort for many, many people, as well as a key vaccinator for students.
And age.
I'm sorry, what was the other?
Do you start with younger kids first?
In the schools. As far as the plans for schools, this is going to differ from county to county. The recommendations for the target group, of course, are a very large age span, 6 months all the way up to 24 years. As far as the school campaigns, most health departments are focusing on elementary schools, but there are campaigns being developed locally for high schools to be the center of the immunization activity, and then invite all of the middle schools and elementary schools in that cluster, as well as the non-public schools, to come to a high school. So there's different ways of approaching this in different counties, and again, the best way is to check the county website and to see what the local plan is. School superintendents and school systems have been tremendously helpful in this partnership, as have school nurses, who have never been busier than they are in this present school year.
Okay, this is a question for either Secretary Colmers or Deputy Secretary Phillips. How is reimbursement for vaccine administration handled?
That's a very good question. Remember again that the cost of the vaccine itself is being paid for by the federal government. It is being financed through federal taxes. The reimbursement for the administration of the vaccine, we have been in close communications with all of the major health insurers in the state, with Medicare, with Medicaid, the private commercial plans, the state employee benefit plan. All of them have mechanisms in place and coding schemes in place to allow for the billing of the administration charge. Now, in public clinics, there are limitations that are placed based on the federal asset. If it is being done in by a public clinic for the public, a free clinic, that there are limitations on that. I'll let Fran talk about what those limitations are.
They'll be free. In local health departments and in school-based campaigns, there won't be a charge for the vaccine at all for the administration, and that's really important for many people, and particularly for families who have lots of children who want to seek access and have an inability to pay. So local health departments will be providing the vaccine for free, as well as in the schools. As the Secretary said, in clinical settings, providers can and should charge an administration fee, which is reimbursable by all of the major carriers that we know of. When the vaccine becomes widespread and it's abundant, and we are able to fortunately then turn to our pharmacy partners, and I want to thank all of you who are waiting for that day when we can get vaccine into pharmacies. Again, as is typical, pharmacists will charge an administration fee, which may or may not be reimbursable by the individual's policy as far as a reimbursement rate. So the administration the administration fee ranges. Typically, it's about $15 is what typically a provider will charge. And again, health departments and school-based clinics will have no charge.
Okay. Question for Ms. Hauck. Several people have commented on the intrusive nature of the consent form. Is every data item required data?
If you're referring to the scannable form, we did indicate the minimum data elements in the provider agreement that are required. And again, those are required by CDC. We also indicated a number of other variables on that form, which we would appreciate receiving the information, because again, it helps us better describe H1N1 in our state and to describe the vaccination administration. But those are, again, requested, not required data elements. Again, we attempted to keep it to the minimum that were required by CDC to report to them, and hope that we can receive that information. For those who are reporting electronically, it's the same data elements that are required by CDC, and the same thing is true for Immunet and for the school-based form. So the data elements that are required are consistent across all four mechanisms for reporting.
Thank you. A general question, why has there been such a delay in the manufacturing of the vaccine?
That is it's not 64,000, it's $2.9 million question here in Maryland. Again, I think the idea of having had only 6 months' time from the first initial report of cases here in the United States to the production of the vaccine itself is rather remarkable. The federal government has contracted with 5 vaccine manufacturers to produce the vaccine. As you've heard, the production and the availability is available in different speeds with different formulations. And so there are issues with the timing and the production of that for certain of those formulations for certain of the manufacturers. It is a matter that is beyond our control or really our detailed knowledge. What we do know is what we receive from CDC on a weekly basis of what they estimate our amounts will be projected over the months from today until the end of the year. And based on that, we can project at a national level, and based on that can project what we will get as our share. As I've suggested, over the first several weeks of this campaign, we have seen a phase shift, if you will, in when we are going to be receiving the vaccine. And so we have had to alter our plans, as I'm sure all of you have, based on that.
A medical question for Dr. Blythe. Please address the issues of spacing between seasonal flu mist and H1N1 flu mist. Especially address the perceptions that those vaccinated with the flu mist are contagious.
Okay, good questions, and I know a frequent question. So the live attenuated influenza vaccine, or flu mist, is a live virus vaccine. It's attenuated, so it doesn't produce the influenza illness that it protects against, but it is a live virus, and it's administered, as those of you who are given the vaccine know, into the nose, and and so you give a squirt into each nostril each time you vaccinate, and it takes a little while for that vaccine to work. and you cannot co-administer two different vaccines because there may be some interference from one vaccine to the other if you administer the flu mist, both types of flu mist, like seasonal flu mist or the H1N1 flu mist at the same time. So that's the reason doses can't be administered at the same time, and because it's a live virus and it reproduces there is the recommendations are to have at least a 1 month gap between administration of any different doses of flu mist or a live attenuated influenza vaccine. And so that would mean if you got a flu mist vaccine with H1N1 today, you would have to wait a month for another dose of H1N1 or for a seasonal vaccine dose. Now, one thing to point out is that there is no gap between injectable doses. So if you got a dose of injectable seasonal vaccine, you could get a flu mist vaccine at any point thereafter, and vice versa. So if you're using a combination of flu mist and injectable vaccine, there is no dose. There is no gap between dosing, with the exception of children who are getting 2 doses overall, and there's a 1 month gap between 2 doses of the same vaccine. And I'm sure I'm making this more complicated, but we have some information on our website that will help clarify that for people to make sure it's clear.
Okay, more generally, who of the target groups are medically eligible for LAIV?
The live attenuated influenza vaccine is not indicated for people who have underlying medical conditions that put them at risk for complications. So people, for example, who have asthma or who have underlying heart disease or lung disease or diabetes, flu mist is not indicated for those groups. So it's for healthy children and adults up to age 50.
And non-pregnant.
Non-pregnant people. So it's good for healthcare workers, for example, who are among the target group. It's good for those adults who are around children who are less than 6 months of age, to those who are healthy and want to protect the infants. So it's good for those groups.
Okay. Why are the ER staff and ambulance staff and other frontline staff not vaccinated yet?
The reason they're not vaccinated is because the vaccine isn't here. The folks you just spoke about are absolutely in the priority population. EMS providers, people who work in enclosed vehicles with patients with influenza-like illness, absolutely, these are individuals who need to be vaccinated, as is ER staff. And so every one of the hospitals is very anxious to fully vaccinate all of their staff. Likewise, EMS providers around the state working in conjunction with their local health department, very anxious to get this vaccine and to vaccinate that staff, because that is an essential workforce, not only to keep healthcare workers and EMS providers on the job and taking care of increased numbers of sick people, but also to assure that healthcare settings is not a setting for virus transmission. So absolutely, we know that it's necessary, and the prioritization work that goes on in the immunization center every day to sort out that vaccine as the little bit that comes trickling in is available to us is sent off to healthcare workers as a very important priority.
Thank you. Are there changes to the vaccine adverse event reporting system specific to H1N1? And also, with respect to the same system, are there changes to the H1N1 surveillance systems to track potential vaccine failure?
The first question about changes to the vaccine adverse event reporting system that's in place, and that's the VAER system, and the answer is no. There are no changes to that. It collects information and reporting is done in the exact same manner as it has been done for some years now. And surveillance, well, we certainly are tracking information, for example, about hospitalized cases, and one of the things that we check into for every hospitalized case is whether or not that person has been vaccinated with a seasonal vaccine or the H1N1 vaccine. So we do track that, at least for some of the cases that we're seeing, and we're involved in trying to look at the effectiveness of this vaccine this year and at seasonal vaccine in previous years. So yes.
Okay, how much mercury is in the thimerosal in the multidose vials? How much is in each injection from the multidose vial? And how much mercury causes problems? This is kind of specific, but I think in a general sense you might answer that question.
I'll take a start. In general, there's just a very tiny amount, a trace amount of mercury or thimerosal in the multi-dose vials, and so each dose, each vial contains approximately 10 doses of vaccine. So each dose would have even a smaller amount of that. So there's very little thimerosal in influenza vaccine.
And there are preparations of the pre-filled?
There are the pre-filled syringes, which contain no preservatives. And therefore contain no thimerosal. And
in the LAIV?
And the LAIV does not contain thimerosal. Thank you for prompting me there.
This, I think, is a big picture question. It's been already asked in another way, but I thought it was the specificity of this is kind of a different direction. There have been multiple reports that have stated by the time we get to the vaccine, we will already have moved past the peak of vaccination efforts and they will be too late. What is your opinion regarding the news reports? Will these reports affect the vaccination efforts in Maryland?
Again, I'll repeat what I said before. We don't know what those models, whether those models will turn out to be correct in terms of the peak. Nevertheless, we will continue to move forward with vaccination efforts because of its importance in protecting the population. For individuals, it matters not where you are in the epi curve. If you become ill, you become ill. And so a way of protecting yourself, your families, and your loved ones certainly would urge you to continue to seek out the vaccine.
Okay. I'm an obstetrician, and I'm getting calls to vaccinate husbands on the high-risk list, parenthesis, those with kids under 6 months of age at home, and children of my pregnant patients under their pediatricians, where their pediatricians have yet to release the vaccine. Since this is not my usual vaccine population, and I have no chart on these patients, how should I handle this?
Right, that's a really good question, and it's a very perceptive one. There are opportunities, there are immunization opportunities that present themselves in a practice and beyond the individual identified patient. To the extent that that practice can work with the department's dose tracking system in order to document that dose, we would encourage you to do so. Right, you would not necessarily have a clinical record on that patient. Whether or not your practice can support opening a very brief clinical record on that patient or not is a question, and it's a good question, and we would urge you to consider that. We would actually like to take that question back and to develop some best practices, some models of where we know in other practices and also in hospitals where perhaps parents who are bringing newborns home, the dad may not be the registered patient, but the dad could be, and that's an opportunity to vaccinate that household contact. We have had discussions with hospitals and with practices about this. They are developing some very streamlined forms, clinical records for that purpose, and we would be glad to share that. So we will get some more information about that.
And post it on the website.
And put it on our website. That's a good point, on the department's website. That's flu.maryland.gov. And then lastly on that point, a fallback is always a health department, your local health department. And so recognizing that they're tight on vaccine supplies, but please consider them as the vaccinator of last resort for priority populations now, for priority populations only at this point in the campaign. Please don't hesitate as a provider who is not able to vaccinate a priority person in your practice to refer that person to the health department, to the website or the flu line, as I indicated earlier.
Okay. Here's a medical question. Do we need to isolate patients for whom we're ruling out H1N1 pending their labs? Can we cohort?
Well, we do. This is I guess I should clarify, for hospitalized patients, there are isolation recommendations, and we certainly recommend droplet precautions, but not airborne precautions in general for influenza. Influenza-like illness, And so that's what would be the recommendation here.
Okay. I have read that infected people shed virus up to 10 days. Is it the same whether or not they are treated? Should we keep them out of care for 10 days, or out of work for 10 days?
Another question. So it's a good question. And so we don't know exactly how long people are infectious, and it probably varies from person to person and from a person's age and so forth, and whether they have underlying immunosuppression, for example. So what we know, though, is that people can shed this virus and can have detectable virus or virus detected for days, even after they're probably no longer really infecting other people or able to infect other people. So, but what the recommendation currently is that people, for example, school children or even healthcare workers in general, but people who have had influenza-like illness, that they should remain at home, not go to work, not go to school for 24 hours after the cessation of fever without having fever-reducing medications being part of that. So for 24 hours after until after fever resolves, and at that point, a person can go back to work or go back to school. The one exception that if you're a healthcare provider, check in with your infection preventionist just to make sure you're clear on the policy, is people who work in special isolation units like bone marrow transplant units, for example, where they may want to have healthcare workers who have had influenza-like illness to stay away from those units for a longer period, up to 7 days or so. And so check in with your infection preventionist to be sure of the policy at your own facility.
Okay. I've heard there's widespread resistance to Tamiflu. Have you seen any resistance to Relenza?
It's a great question. And first, to correct what may be a misperception, there is not widespread, fortunately, not widespread resistance for this 2009 H1N1. There's not widespread resistance against Tamiflu. And so we're glad to see that, and we are monitoring for resistance. We've not seen it at all in Maryland. There have been sporadic reports throughout the United States. And there is likewise no resistance detected or identified to date against Relenza. But it is something we're careful about. It's something we monitor carefully, and it's also information that we put up on our website for providers to take a look at and be aware of.
What is the level of protection afforded by N95 masks for healthcare workers?
You guys are doing all the tough questions here. It's this is I will just acknowledge it. This is a controversial area right now, but there is a recommendation from CDC that healthcare workers involved in care of patients with H1N1 or suspected H1N1 use. There should be a variety of different measures in place to try to prevent infection of healthcare workers. And most important are probably the administrative and engineering controls that can be put in place, and those sorts of things. But in addition, there is a recommendation about the use of N95 respirators to try to prevent what may be some level of airborne transmission of H1N1. And so that's it's a difficult area because we recognize the difficulty of doing that, number one. Two, the very practical limitations that there aren't sufficient mass N95 respirators around. And so it's something that we will be watching, and I'm sure as will many other groups, and working with you over the course of the next few weeks and months as these recommendations get really refined in practice.
I would also add that if you're interested in reading the guidance specifically, because it's a rather lengthy document and it's worth the read, it's available at the CDC website.
Please, this is from one of our health officers. Please address perceptions that LAIV is contagious.
Go ahead.
Yeah.
Good. Thank you, Dave.
Sorry, I could start.
Good question.
It's a good question. Yes, it's a live virus. However, there really aren't, It's really not something that where there's a recommendation that people who receive this vaccine need to isolate themselves to prevent from infecting other people with the virus that, again, is an attenuated virus. It's not the influenza virus per se that causes a severe illness, et cetera. But anyway, there is no recommendation for people to isolate themselves after vaccination with the live attenuated influenza vaccine, with, again, one exception, and that's healthcare workers who work in those specialized units like bone marrow transplant units where, again, just being particularly cautious, the recommendation is that those people not work for the 7 days following their vaccination. If they were to be vaccinated with LAIV, really that's an opportunity to use the injectable vaccine really for those people.
And just on that point about LAIV meaning the nasal spray, for people that can take it, it is a safe vaccine. And in fact, it is the vaccine formulation in Maryland where we have the most supply. That will change over time as we get more and more of the injectable in. But it is a vaccine that is absolutely appropriate for healthy children over the age of 2, healthy adults, and that includes, by and large, the vast majority of healthcare workers and of EMS staff. So again, if you have the opportunity to be vaccinated with LAIV, the nasal spray, and you're a healthy adult, go ahead and do so. It's good. It's safe. And this is a recommendation that we recognize has changed in the last several years. And so I think that part of this, the perception is now catching up with what the guidance is.
Is there a shortage of pediatric pre-filled syringes?
There really are very few, and in fact, we've had no pediatric pre-filled syringes available, or the dosages for the very young children available here in Maryland, or I believe anywhere in the country at this point. So yes, shortage, but there just hasn't been any distributed yet.
Okay. The questioner is asking about the state's pan-flu absenteeism policy, something that may be replicated in the private sector, we hope, that about no requirement for documentation for illness from the flu.
For individuals, the state of Maryland has, for its workforce, put in place a leave policy that would make it a little bit more streamlined with respect to people who are self-reporting influenza-like illness, not to be required to go to a physician's office in order to get a doctor's permission slip to return to work. We are working also with the local school systems to ensure that that policy is in place as well. The last thing we want to do is to encourage people to go to their health care provider to simply get a note to return to work or to school following resolution of this illness. It's a way of keeping them out of the healthcare system.
Thank you. From a federally qualified health center, we did not receive our full initial order of vaccine. When should we reorder? Will you automatically send me our remainder of our initial order when the vaccine is received?
Yes, we will. There's no need to reorder the difference between what you received and what you placed in your initial order. Again, as more vaccine becomes available, we will be fulfilling the orders as fully and as completely as we can as the formulations are available and as our allocation indicates. So there's no need to reorder. We keep those in the system, and we will fill those as we have the allocation available. And again, if you have a specific question, just send it to the email, and we can try to address it specifically. But in general, we will be filling the orders as completely as we can as the vaccine becomes available.
Probably another question for you, Ms. Hauck. What addresses do providers use to send the forms back to DHMH?
It's a great question. I actually don't have the address in front of me. It is on the website. We do have a copy, a non-usable, non-printable copy of the scannable form that has the instructions. And again, you can email the specific question to H1N1 info, and we'll be sure to get back to you with the specific address.
Okay. I've been trying up to now to sort of get broad questions that everybody could answer, or the broad variety of providers could respond to. We're going to get some more specific questions. We may get some more answers like that we don't have all the information here. The information accompanying the vaccine stated that moderately, severely ill people should wait to get the vaccine. Do you have any recommendations as to how long a person with mononucleosis should wait?
Yeah, that's a good question. I think there are probably a lot of variables that would go into answering that question. Variables about the the person's condition otherwise and so forth. So I don't have a specific answer for that. But in general, it's just a moderate to severe illness, and once that's resolved, people can be appropriately vaccinated. But if there are specific if we need to follow up specifically, we can do that directly.
If children that are now 3 to 5 years old but were born premature, are they at higher risk than other kids?
That's another good question, and again, generally difficult to answer in a general way. But no, not in a general way. There might be certain conditions associated with prematurity that might, for example, some persisting lung problems that might put a person into a risk group for complications, but in general, no.
This is from a practice manager in Baltimore County. I have a patient from Pennsylvania who is high risk. How do I fill out the consent form? The county codes are only for Maryland. Can I leave the county code blank? There are several issues which people might want to answer in regard to answering this question.
I'll address the county code piece of it specifically. You may leave the county code blank, fill in the other information as it's requested. We will get the form and either share it with our partners in Pennsylvania or categorize it as an other in the data reporting system. Again, if you have an opportunity to vaccinate that individual, please do so. Again, if the opportunity presents itself and you have the capacity and the ability, it's important to go ahead and deliver the vaccine. The reporting form can be filled out with those modifications and sent in.
And let me just add on top of that, that's a critically important point, that we are working in very close cooperation with our bordering jurisdictions, with Virginia, with the District of Columbia, with Pennsylvania and Delaware. And that is to say that as individuals present themselves, we are encouraging them, regardless of where they present themselves, to go ahead and get vaccinated. And that is the general approach all of the jurisdictions are taking.
General question. I heard that some people have died from H1N1 vaccine. Is it true or rumor?
I have heard of no case of a death associated with the vaccination. The clinical trial information that came out was so far been very positive in terms of results and adverse reactions.
Okay, thank you. Can pregnant women get the live flu mist and H1N1 mist? The package says so.
No, and I just to reiterate that, no.
Okay.
No.
I meant from previous conversation, but no.
This might come from recent news reports. If we are not testing patients as was initially done, how can we say that we're either seeing more or less cases of H1N1?
That's the whole point of a surveillance system. You don't have to test everyone. If you have a system in place that allows you to look around the state at a fair sampling of people across different parts of the state, of those people who are being tested, it's a good way of being able to estimate what the growth is. And those charts that we're seeing earlier are based on individuals who are showing themselves presenting themselves with influenza-like illness, and the other charts are for those where we are seeing lab-confirmed results with that population. So we think it's a pretty good way of estimating it. We don't test 100% of the flu in the seasonal flu campaign. There's no need to do that here. And David, do you want to, after that free advertisement for epidemiology and
thank you
value?
Thank you very much. Yeah, that's exactly right. We do have a system in place to try to sample throughout the state and throughout different age groups and different types of people to get a sense of what viruses are circulating, and including to confirm that H1N1 is still here and the activity is increasing, and it is.
This is relating to a specific hospital in the capital region, but it more or less, I think, would behoove us to answer in a general manner. When will the supply of specific hospital receive their supply of H1N1 vaccine? They have the only NCIU and PCIU in the county.
Again, if you can email the specific request to us, we can take a look at that situation. We have actually shipped vaccine to almost all of the hospitals in the formulations that are available and were requested. So if you can email us the specific information about your hospital, we can try to look back and see what has been ordered and take a look at your order and see what we can order for you.
So, for example, to be very specific on that, if you only ordered pre-filled syringes, you are not likely to have gotten your order.
Correct.
If you have ordered LAIV or if you've ordered multidose vials, you may have gotten some of your order placed.
You most likely have gotten some of the, again, based on what was available, you've received some.
And again, finally, to follow up, because of the question that was asked earlier, if somebody wants to change their order based on what that formulation is, you said that we are developing a form that Correct. They can apply for and use that as the basis of, and in the meantime certainly can send an email to the vaccine program to raise that question to alert us.
Correct.
And that comes to the ends of our questions. We've had a prolific question and answering session. Thank you, folks, for being so forthcoming in answering everything that we've put out here. We now have a conclusion of today's event, and I'd like to express the department's appreciation to all of our speakers today, Johns Hopkins School of Public Health, and most particularly all those participating in today's webcast. Please complete the evaluation form on the web. The webcast will be recorded and available on this website and on the DHMH's website, as well as each of the questions. We will respond to each of the questions and do a question and answer on the DHMH website so that people will be able to take advantage of these, even though they may not have been able to get the webcast. So thank you very much for participating.